with Dr. Khalid AlKarbi about the common infectious disease. Dr. Khalid AlKarbi, primary healthcare corporations in Qatar, family medicine residency program in Qatar also, graduate of Cardiff University in the UK, consultant of family medicine, training of faculty of the family medicine residency program, masters of medical education from Maastricht University, teacher assistants of teacher assistants of the BBCR program affiliated with Harvard University, members of the curriculum committee of the Arab board, and head of clinical training and the BHCC. دكتور خالد الكربي معنا.
السلام عليكم.
هلا صباح خير دكتور خالد.
يا هلا ومرحبا دكتور،
الله منورنا دكتور.
خير الله يعافيك ويسلمك، شلونك؟ ان شاء الله مرتاح.
الله يسلمك، حياك الله منورنا.
Okay.
المايك is yours دكتور خالد، تفضل.
Okay, thank you very much for the kind words and very nice introduction. First of all, I would like to thank you all, like for hosting me to do this talk. So I will start with my presentation because, it's going to be a very long presentation. We will try to finish it in an hour as much as possible. So this is my presentation. So my presentation is was supposed to be approach to acute diarrhea, rash, sexually transmitted.
Sorry, doctor, can you share the screen?
Oh, sorry. Okay, just a minute. How can I share it? I think it's yeah, share. Okay, privacy and security. Oh my God. Just a minute, I think. Okay, so open system sensors, open system settings, security and privacy.
There must be a share screen down green color, a green highlighted tab.
Yeah, I've done that. Okay.
دكتور خالد يعطيك العافية.
الله يعافيك.
بس تقدر تطق على شكل سير اللون الأخضر اللي من تحت.
ايه طقيت عليه بس
طقيت عليه وبس البرزنتيشن ما تقدر تختاره إذا كان اوريدي مفتوح.
ما هو هذا وفتحته بس انه ظهر في security reasons something like that. Okay, you can okay, for some reason okay. فطقيته الحين مرة ثانية share. Yeah, okay, got it. Can you see it now?
اي دكتور تمام جميل.
شيء تمام اوكي.
بس دكتور لو تكبر الشاشة بس اللي هو ايوه تمام.
الحين؟
Okay.
تمام.
Perfect.
Okay. Apologies for that. So we have our presentation today was approach about acute diarrhea, rash, sexually transmitted infections, and HIV. It would be illogical, to address all aspects of those infections and those cases, in one presentation. However, I decided to go for the most important thing and focus on the updates, as there has been so many updates in those areas in the past few years. Okay, so. I will start with the formalities first. So disclosure statement, I have no relevant financial relationship in this product or service described, reviewed, or compared in this presentation. Then we will go for the objectives. Hopefully by the end of this presentation, I'll be able to provide a systemic clinical approach for diarrhea, rash, sexually transmitted diseases, and HIV. discuss the diagnostic methods available in the primary care setting, and I would like to emphasize on the primary care settings, overview of the management options in the primary care settings, highlight the recent updates in the management plans of the selected cases. Just as a brain teaser, like I will start with a very quick case. This is a case of a 30-year-old male present to the clinic with a complaint of diarrhea for the last 4 days. He reports that diarrhea started 1 day before he came back from Egypt and has been frequent, severely affecting his daily life activities. He denies any bleeding, vomiting, or signs of dehydration. He feels tired, but is tolerating oral intake. On examination, he's vitally stable with no abdominal pain, fever, vomiting. He's married and he has no extramarital relationships. So the question is, and this is a very common MCQ question in the exams, by the way, which of the following is the most likely cause for this patient presentations? The rule of thumb, and this is what my uncle, Dr. Ahmed Bouazir, who has a master in travel medicine, he said, Khalid, if the diarrhea, is not severe, is not bloody or anything, just go for traveler's diarrhea. And this is the most appropriate answer. So this is traveler's diarrhea. However, the next question that comes into my mind, which of the following is the most likely cause of the diarrhea? I put this question even though they are looking very simple. However, the answer can vary depending on the history and depending on the cases. So most likely, if it is just a general question, the most likely cause of traveler's diarrhea, it's always enterotoxigenic E. coli. However, this depends on the presentation of the patient, and we will explain it further in the next slides. So the most important thing that we have to inquire whenever we have a patient with diarrhea or traveler's diarrhea, first of all, is the onset. Onset is very important. Duration, how long it has been there, this is very important as well, because duration can dictate, the type of treatment or the type of treatment option that we can give for the patients. Severity, if it is affecting the daily life or not, this is very important, as there has been some changes in the meantime that antibiotic can be started earlier than before if it is very severe and if it is affecting daily life, or if some guy, is going for a conference or something and he needs to be diarrhea free. So maybe we can start an antibiotic. The frequency of diarrhea should be noted as well. Then another important question is the stool characteristics, so watery diarrhea. If we have a watery diarrhea, usually this is not alarming and we can wait for a bit before we start giving any medication. However, if it is bloody or mucus filled, this is a sign for infectious or inflammatory diarrhea, and antibiotic should be started ASAP. Signs of dehydration, this should be inquired like at all cases, regardless of the previous questions. Any signs of dehydration is very important, as we need to address it aggressively and start IV fluids if needed. Food and travel history is always helpful, because let's imagine that we have a patient who just came from Egypt or who just came from India, where there are loads of street foods. Another, the list of differential diagnoses will be expanded, and another important diagnosis, differential diagnosis can be included, and we will go through them. Daycare. Yeah, daycare. So, with children, we have always to ask if there are some other children who are having diarrhea and vomiting as well, because this is most likely a norovirus. Nursing home residents. The nursing home residents are the source of many outbreaks, and those cases in nursing home cases, should be addressed aggressively, and mass investigation should be done and treat the causes. Recent hospitalization is very important. As we know, the C. difficile, could be always secondary to a recent hospitalization, and we should inquire about them. Finally, sexual practices that include receptive anal or oral anal contact. this should be included, as well as this could include expand the differential diagnosis we are having. This is a slide for showing clues of the diagnosis of acute diarrhea. I'm not sure if it is clear for you guys, but you will have the presentation and it will tell you, you know, like which clues or which signs and symptoms, you know, like related to which pathology. Now we move to the diagnostic testing. So this is where the first bit of update comes in. I remember before 2022, before 2020, yeah, with diarrhea, it was 2020. Most patients who are immunocompetent with acute non-bloody diarrhea without symptoms do not require stool testing. This still applies till now. If someone is immunocompetent, non-bloody diarrhea, just don't do the testing. Start with him the treatment, which is the supportive treatment. However, stool studies, now this is the change. The stool studies should only be obtained for the following groups. Acute bloody diarrhea should be done, we should do the studies. Fever, if it is more than 38 and lasting for at least 3 days or more. Severe abdominal pain, should warrant testing. Signs of sepsis or duration of 7 days or greater. So if you have someone who's having diarrhea, even if it was non-bloody diarrhea, watery diarrhea, however, it has been there for 7 days and he's vitally stable, not dehydrated, we should start him on studies. So, and finally, patient with occupational or residential risk factors for an outbreak, such as elderly in daycare, nursing homes. So we have molecular or culture independent studies, so also known as multiplex polymerase chain reaction, which is a PCR, as we know, or a nucleic acid amplification test, are generally preferred over the traditional stool cultures. And the reason for that is that the single stool culture costs around $900 per test. You know, like on the other hand, PCR can cost about $150 per test. You know, like, so we can and they can give you an indication of the pathogen, very good picture or very good indicative about the pathogen that we need to target. If a clinician suspects an outbreak requiring a public health investigation, separate stool cultures are required. So if we are suspecting an outbreak, just go for the stool culture. You don't have to do the PCR and then do the stool culture. C. difficile, as I mentioned, it has to be suspected and tested for patient with a recent hospitalization for the past 12 weeks. Or if a patient has been given an antibiotic in the last 3 days. And the method of testing is the nucleic acid amplification testing. Okay. Blood testing is not routinely recommended for now for patient with acute diarrhea. Fecal leukocytes, lactoferrin, and calprotectin. It used to be recommended before 2020. However, right now it's not recommended anymore. Okay. And this is our approach for a patient who comes to us with with diarrhea. So basically, we start with loose diarrhea for more than three loose diarrheas or watery stools per day. The very first thing, you have to start with assessing of dehydration. If he needs a dehydration, just start the supportive treatment right away and then look for the other things. Then we look for the some signs and symptoms, and the most important signs and symptoms is there like any persistent fever? Is there like a bloody diarrhea, or is there like recent travel, severe abdominal pain, and things like that? If these things exist, and symptoms lasting for more than 7 days, these things exist, you know, like we have to start investigations such as PCR or culture, depending on the case, and then start antibiotics. Management. The treatment for acute diarrhea depends on the suspected or determined cause. Supportive therapy with early rehydration and refeeding is recommended regardless of the etiology. So the very first step is always supportive treatment with rehydration. This is a question that we might always be asked. doctor, what should I give my child? Or doctor, what should I take whenever I have a diarrhea? So these are like few recipes that have been suggested by the American Academy of Family Physicians. And those are the recipes, as we can say, the chicken broth. So 2 cups of liquid broth, 2 cups of water, and 2 tablespoons of sugar. That's like another one option. Gatorade is another option. I'm not sure if they have paid, Gatorade have paid them or something, or they participated in this presentation, this study. However, you know, like 32 ounce of Gatorade plus 3/4 teaspoons of salt can be another recipe for it. The last resort is the water. So 1 quart of water, teaspoon of table salt, and 2 tablespoon of sugar. So these are the recipes that can be given to the patients to replace their fluids. However, if they do not tolerate oral rehydration, we should start them with IV fluids. Now we come to the next bit of the of updates. So it's the empiric antibiotics for traveler's diarrhea. I remember back in my time, and my time wasn't that old, you know, like it was before 2022. It was ciprofloxacin, you know, like ciprofloxacin, everyone was taking ciprofloxacin, you know, like I used to take, okay, I'm guilty about it, but I used to take ciprofloxacin as a prophylaxis to me, even though it was not recommended. But, you know, like just in case, ciprofloxacin was the recommended first line treatment for traveler's diarrhea, except if you are going for Southeast Asia. So for those who were going to Southeast Asia, we were recommending for them azithromycin because of the resistance of Campylobacter in Southeast Asia. However, in 2022, this thing has been changed. You know, like azithromycin has become the #1 option, and ciprofloxacin stepped back into #2. So we have 2 regimen for ciprofloxacin for azithromycin. So we have either the single dose of 1 gram or 3 days dose of 500 milligrams per day. Ciprofloxacin now it's like either 1 dose 750 milligrams or 500 milligrams for 3 days. This is like another details, you know, like for the organisms and what antibiotic we can give. You can look at it at any time. Now we come back to the last question for the anti-diarrheal medication. I remember anti-diarrheal medication, especially loperamide, we used to recommend patient not to take it as a prophylaxis. However, right now the new recommendation says that loperamide and simethicone, anti-secretory properties of bismuth and anti-motility properties of loperamide makes these 2 drugs the most useful symptomatic therapies for acute watery diarrhea. And I insist on the word watery diarrhea. Guys, you have to be careful with that, and can help decrease the inappropriate antibiotic use. It wasn't the situation back before 2022, before the last updates. Loperamide and simethicone combination has demonstrated faster and more complete relief of acute watery diarrhea and gas-related abdominal discomfort compared with either medication alone. So it's better not to start loperamide alone. Start loperamide and simethicone. In cases of traveler's diarrhea, adjunct loperamide therapy with antibiotic has shown to increase the likelihood of a clinical cure at 24 to 48 hours. So right now, this wasn't the situation before. You know, like right now it stays, start loperamide as soon as possible. However, loperamide and other anti-motility agents should be avoided in patients with bloody or suspected inflammatory diarrhea. So this is the most important thing that you have to keep in mind. So you have to tell your patient, guys, if you have a bloody diarrhea, don't take the anti-motility medication because of toxic megacolon and prolonged illness. Bismuth are safe alternative for patients with fever and inflammatory diarrhea. So bismuth can be given for patients with bloody diarrhea. This is a summary of the practice for our talk about diarrhea. So stool culture or PCR testing should be reserved for patients with evidence of invasive diseases, immunocompromised, prolonged illness, and increased risk of involvement in an outbreak. We have rehydration is the first line treatment of diarrhea. with oral rehydration being preferred method for a fluid replacement. In combination, loperamide and simethicone may provide a faster and more complete relief of acute watery diarrhea and abdominal discomfort than either medication alone. When using antibiotics for traveler's diarrhea, adjunct loperamide shortens the duration of symptoms and increases the likelihood of a cure. However, guys, be careful of bloody diarrhea. If it is a bloody diarrhea, don't give loperamide. Empiric antibiotics can lessen the duration and the severity of symptoms in moderate to severe cases of traveler's diarrhea. So that's it for rash. So now we move to the, that's it for the diarrhea. Now we move for the rash. I will start with the brain teaser as well. So, and this case is a real case. It's a case that what happened to my son. When he was 4 years old, like he presented to the clinic with a sore throat that had persisted for 4 days. His mother reports that he developed a fever for 39 degrees Celsius has not been coughing. He wasn't having any cough. Yesterday, she noticed a rash that appeared on his trunk and has since spread. On further questioning, the mother mentions that he has been more irritable than usual and has a difficulty in swallowing. On physical examination, the child appears uncomfortable and slightly flushed. His throat is congested with enlarged erythematous tonsils that have patches of exudates. The rash observed is confluent, erythematous, and blanching consisting of fine macules and papules. His tongue appears red with a swollen papillae, giving it a strawberry appearance. The child's cervical lymph nodes are also palpable and tender. So what is the most likely diagnosis? If you have a child like that, what would be the most likely diagnosis? I remember when my son came to be like this, like I remember I said, most likely it's an acute tonsillitis, so I will give, but I wasn't sure that it is bacterial or not. And I was lazy at that time. And I said, something, if he's not okay by tomorrow, I will take him to the hospital and I will bring an antibiotic with me. However, tomorrow we had this was the rash. So what would be the cause? What is the most likely cause? So just for the sake of time, because we may not have enough time, this is a scarlet fever. And the reason it's a scarlet fever, we will go to it right now. Incidence of scarlet fever in England and Wales has declined from 1940s to the mid of 2010s, but has increased markedly in the 5 years leading up to a pandemic lockdown of 2020. Poor guys in England, they had the lockdown of COVID in 2020, and they had the lockdown of scarlet fever as well. Scarlet fever is diagnosed in 10% of the children presenting with streptococcal tonsilopharyngitis. So it's like 1 in every 10 tonsillitis could be a scarlet fever. So you have to make sure that you diagnose it early. It is caused by a certain strain of a group A beta hemolytic streptococci. Recognizing scarlet fever and commencing antibiotic and public health action reduces the risk of sequelae and an onward transmission. Usually diagnosed from symptoms and signs alone. So right now you don't really need any test for that. It's just the symptoms and signs, and then it can give you an idea that it could be scarlet fever. So scarlet fever, the condition usually follows a streptococcal throat infection. This is what happened to my son. I thought, okay, it's most likely tonsillitis. I'll bring the antibiotic tomorrow. I'm too tired to go to the hospital. However, then the rash appears. The rash appears characterized by fine erythematous blanching rash with sandpaper structure, often starting on the trunk. And this is very important, prodrome, like usually the rash starts in the trunk and then spreads to the extremities. The presence of sore throat, fever, and the characteristics rash are the clinical key features. So if you have this trial, like you don't have to wait for the test. Just start the treatment. Strawberry tongue and fascia lines or the linear petechiae may be and may not be observed, so you don't really count on them. So the diagnosis, most children have a fever and sore throat 1 or 2 days before the rash develops on the trunk. The rash spread throughout the body, sparing the palms and soles with characteristic of circumferential pallor. Rapid antigen tests is the routinely used in clinicians. So this is what we do in the primary care setting, like because we have it. However, throat culture is always is the first choice method for diagnosis, but it's not always practical. And the reason it is the best method is because of its high sensitivity. But in primary care, no, we just do the rapid antigen test. And I believe in the exams, like if you have both of them, you just go for the rapid antigen. Therefore, cultures may be ordered when the suspicion of a group A streptococcal infection is high, but the rapid antigen test is negative. You can go for the cultures or only if you think that if the center criteria is really high, but the rapid antigen test is negative, just do the culture, like to look for this extra 9% that could give you the what you are looking for. Okay, the treatment, penicillin is still the therapy of choice for streptococcal infection. Let me tell you, for the sake of exams, it's always penicillin. Just go for penicillin. However, I think I've only prescribed penicillin twice in my life. Amoxicillin or augmentin is like always the choice we have in the meantime. So, and they work, they're okay. However, another option could be oral macrolides. And the reason for that, we can always consider macrolides if there are like allergies to penicillin. Mothers would come to you sometimes and say, doctor, you are giving me augmentin, you're giving me all those antibiotics, but it's very difficult for me to give my son an antibiotic twice a day. So cefuroxime could be an option, although I don't like it, but it's there depending if the mother insists. However, for the sake of exam, penicillin, for the sake of practice, penicillin, amoxicillin are the #1 choice. Early diagnosis and treatment are crucial to prevent potential complications such as rheumatic fever. This is the importance of it, like it is a tonsillitis, like maybe we take it lightly. However, like the sequel or the complications such as rheumatic fever can last with the child, untreated child for the remaining of his life. And post streptococcal glomerulonephritis as well. It is recommended that children should skip school. So when it comes to school, you ask the mother, like that the child should skip school until at least 24 hours of starting the antibiotic. This is another case scenario. We have the same 4-year-old male present to the clinic with a sore throat that has persisted for 4 days. The mother reports that he develops a fever of 39 Celsius degree, a cough. So this time he has a cough, runny nose. He has a runny nose as well. Yesterday, she noticed that there is a rash that appeared on his face and trunk and neck. So this time, the starting points of the rash is different. It's the face and neck, and now has a spread to his trunk. On further questioning, the mother mentions that the child has been more irritable than usual with a decreased appetite and general malaise. She also notes that he has some difficulty sleeping due to the discomfort in his sore throat and rash. On physical examination, the child appears to be tired and comfortable. He has congested throat with large erythematous tonsils and that have patches of exudates. His eyes are red and watery with conjunctival injection. So he has a conjunctivitis as well. The rash observed is erythematous and maculopapular, starting on the face and neck and now spreading to the trunk and extremities. The rash is non-blanching and confluent in some areas. There are small white spots. Sorry. Okay, there are small white spots with a bluish center in the buccal mucosa, complex spots. The child's cervical lymph nodes are palpable and slightly tender. For the sake of time, so in this case, the answer would be, or the diagnosis would be measles. And the reason for that, measles is caused by a virus in the virus family, passed through a direct contact and through the air. The virus infects the mucous membrane. That's why it affects distinguished areas such as, that's why we have the patient with cough, runny nose, and conjunctivitis, you know, like, because it starts with those areas, it starts with the mucous membrane, and then it spreads throughout the body. The first sign of measles is usually high fever, which begins about 10 to 11, 12 days after the exposure and lasts for about 4 to 7 days. A runny nose, cough, and red watery eyes. These are the 3 C's that you have to remember, and they are always associated with measles. So if you have a very sick child with rash and 3 C's, that's are the coryza, cough, and conjunctivitis, always think about measles. Measles is highly communicable. Measles infectious from 4 days prior and 4 days after the rash onset. The maximum infectiousness occurs between onset of prodrome throughout the first 3 to 4 days of the rash, which is the same thing, 4 days prior and 4 days after. Immunocompromised persons may shed the virus for several weeks after the acute illness. There are no asymptomatic infection carriers. So it's you either have the full-blown picture of measles or you don't have it. Okay. Most measles-related deaths are caused by complications associated with the disease. The most serious complications include blindness, encephalitis, severe diarrhea, and related dehydration, ear infection, or severe respiratory infections such as pneumonia. So, unfortunately, those things, even though they are rare, however, they are still there. And we should remind the family members who are aware, who are really afraid of the MMR vaccination, you know, like these complications could happen for your child if he develops measles. Treatment, there is no specific antiviral treatment that exists for measles virus. Severe complication from measles can be avoided through supportive care that ensures good nutrition, adequate fluid intake, and treatment of dehydration with oral rehydration solution. Yeah. The last diagnosis in rash that I've been asked about is the roseola infantum. This is also known as the sixth disease or xanthum septum. A common viral infection that primarily affects the young children between the age of 6 and 3 years old. So we will not have that poor 4 years old toddler anymore, you know, like, so he should take a break by now. But usually roseola infantum will, as the name indicates, infantum, you know, like will affect a younger group, younger age group. Caused by human herpes virus 6, this is the most common answer. However, less commonly can be caused by herpes virus 7. So I've seen it a couple of times, comes into in an MCQ. So HHV6 is like the most logical answer here. Clinical presentation, the initial symptoms of roseola infantum is a sudden onset of high fever. You know, like you will have a child with a high fever. The fever could be really high. It could reach up to 40. The fever typically lasts for 3 to 5 days. And then all of a sudden, the child is fine. But once the child is fine, he will have the rash. So basically with the previous infections or the previous rashes, you know, like the child will still have the fever and will have the rash. However, here, the fever will go away and then the rash will appear. During the febrile phase, the child may appear irritable, lethargic, and may experience mild respiratory symptoms such as runny nose or cough. Once the fever subsides, a rash may appear on the child's trunk and spread to the extremities. So this is similar to scarlet, as I mentioned before, usually lasting 1 to 2 days. Management, in most cases, roseola infantum is self-limiting illness that resolves without specific treatment. The focus of management is like symptomatic relief, supportive treatment. In rare cases, complications such as febrile seizure may occur during the febrile phase, but the prognosis is usually excellent. That's it for rash. So right now we move to the third parts of our presentation, which is the sexually transmitted diseases. Sexually transmitted disease, I have divided the sexually transmitted disease into the complaints. So the first one is the urethritis or cervicitis. So the most common players when it comes to urethritis and cervicitis are the chlamydia and the gonorrhea. They usually characterized by dysuria, urethral pruritus, or burning, and or visible discharge. You know, like I don't know, in primary care, this is very common, you know, like, and the biggest complaint that we have, you know, like, is the first void in the morning is like the most difficult one. And there are like stains in their underwears, you know, especially males, stains in the underwears, white stains that could indicate, you know, like a discharge. For the gonorrhea and chlamydia are most common causes. However, in the United States, especially in the United States, another big boy in urethritis starts to emerge, and this is the Mycoplasma genitalium. Patient with suspected urethritis should be evaluated for gonorrhea and chlamydia using the nucleic acid amplification testing, and patient with persisting symptoms should be tested for Mycoplasma genitalium infection. So let's say that you have a guy with urethritis, you start with the gonorrhea and the chlamydia, and you start the treatment. If it is persistent and still no response to the medication, now you have to consider the Mycoplasma genitalium infection. Patients with cervicitis are often asymptomatic. So ladies, usually they will not have discharge. Untreated infection, however, it is important to address them as soon as possible, as the untreated infections can develop into pelvic inflammatory diseases and further complications. Now we come to the updates in the treatment of urethritis. I remember in my time, it was the combination therapy. We used to say, you know, like, get the machine gun and address everything that could be the cause here. In our time, we used to give ceftriaxone and azithromycin. And the reason for that is like, okay, we know that everything is indicating that this infection is gonorrhea, but you never know. Chlamydia could be there, and start treating chlamydia as well. However, right now, it says no, this is not applied anymore. Ceftriaxone is the only recommended treatment for now. Test of cure is not necessary for people with urogenital or rectal gonorrhea. However, the recent recommendation states that another test of cure in 2 weeks should be warranted for patient with pharyngeal infection. So pharyngeal gonorrhea, yeah, you have to do the test of cure. Doxycycline has emerged as the treatment of choice for chlamydia infection, and this is like a new updates. Back in our time, it was azithromycin 1 gram, give it once, and that's it. But right now, azithromycin is becoming number 2 option, and doxycycline has emerged as the treatment of choice. Patients diagnosed with Mycoplasma genitalium should ideally be treated in 2 stages approach using the resistance guidance therapy. So the first approach, you start the doxycycline right away, and send the sample to culture and look for the resistant test. So followed by, and after you finish the doxycycline, you should follow that with either azithromycin, if it is macrolide sensitive, or moxifloxacin, if it is macrolide resistant. Okay, so Mycoplasma genitalium is becoming, it's a stubborn boy. He's a stubborn boy, you know, like we should be prepared for him, you know, like, even though, alhamdulillah, till now, I've never seen any. Then the other common cause is like the bacterial vaginosis. Vaginitis tops the list of gynecological diagnoses in the primary care. The USPSTF recommend against routine screening for asymptomatic patients, including pregnant people not at risk of preterm delivery. Bacterial vaginosis can be diagnosed in office. I remember when I was in the UK, you know, like, we used to do it all the time in the surgeries. So we will just first start with testing the pH. So usually they will have a basic background, you know, like the pH will be high, more than 4.5. Microscopy showing occlusive cells. I've never seen occlusive cells, but not even in the UK, but it was always there in the exam. So whenever there are like Q cells, just go for BV. However, whiff test is something that I used to do all the time in the UK, you know, like, and the whiff test, you know, basically you put a chemical on the sample and then you just take a sniff and whiff. This is why it's called the whiff test. And usually they will have a very fishy smell. So we used to end up with a very bad headache by the end of the day. As for the treatment is still the same: metronidazole 500 milligrams BID for 1 week, or we can give the gel 0.75% daily for 5 weeks. However, there is like an update for the multiple recurrence after completion of recommended regimen. So some people will have the BV that is resistant to treatment, or like the single treatment or the previous mentioned treatment is not enough. So metronidazole 500 milligrams twice daily for 7 days, followed by intravaginal boric acid 600 milligrams daily for 20 days, and suppressive 0.75 metronidazole gel twice weekly for 4 to 6 months. So it's a very aggressive regimen that could be given. Like this is one way. I will not go through the rest of them, but like maybe the most convenient one that we have, and I've only used it once, is a suppressive therapy with monthly oral metronidazole 2 gram administered with fluconazole. Like I've seen this a couple of times, in clinic. We have the third player in sexually transmitted infections is the trichomonas. So caused by Trichomonas vaginalis is the most common non-viral STI. The rates are highest among women 40 years old and older. Physicians should test symptomatic patients with vaginal discharge at presentation, and annually test asymptomatic women who have HIV. So this is the thing, like for ladies with HIV, just do the trichomonas tests, like annually. Physicians should consider testing asymptomatic patients in high prevalence setting and those with a risk factor of STI. So those are the two, according to the CDC, those are the two groups that should be tested. So the diagnosis is still the same. The wet mount is commonly used nowadays. Wet mount has a low sensitivity, therefore negative wet mounts should be confirmed with a higher sensitivity molecular diagnostic testing, but we still do wet mounts till now. Treatment, metronidazole 500 milligrams BID for 7 days. It's the same thing. Sexual partners should be treated as well. Persistent trichomoniasis should be treated after confirming no risk of reinfection. So the first thing you have to do, once you treat a patient with trichomonas and he comes back again, you should differentiate whether this is a reinfection or whether this is a resistant trichomonasis. So if we know that this is not a reinfection, maybe we can go for a more aggressive approach, which is the 2 grams of metronidazole or tenadazole for 7 days. Now we have syphilis. Syphilis for diagnosis, the updates that we recently have is to use the treponemal antibody test. Treponemal, even though treponemal tests, like has been there for a very long time. However, the agent was very expensive till I think 2019, where a new agent has emerged into the market, and it was so much cheaper. And almost all the organization in Qatar, like we has just shifted to treponemal antibodies for now for diagnosis purposes. However, the treponemal test, if it was positive, like we still have to do other tests such as the rapid plasma antigen or the VDRL for confirmation. The non-treponemal antibodies, which are the RPR, this is the most common one that we are using, declines over time with the treatment. So the only reason we still do it, we do it just to measure the response for the treatment or to see if there has been a reinfection. For patient with a history of previously treated syphilis infection, a 4-fold increase or a 4-fold decrease, it could go either ways in RPR, suggests reinfection or suggest treatment or cure, respectively. So if the titer has increased for 4-fold, this could be a reinfection. If the titer has decreased into 4-fold, so let's say the titer was 1 to 16, and it has become now 1 to 4. So 1 to 4, that means he's treated. But if it was 1 to 4 and it's jumped into 1 to 32, for example, it's mean no, it's not treated. This is a reinfection. The preferred treatment remains penicillin. However, for penicillin, you have to be careful. You have to take a very thorough history and know for how long the infection has been there. So if the infection has been there for less than 1 year, we just give one dose of 2.4 million units IM injection can be sufficient. However, who knows how long a patient was infected by syphilis? I never trust, like patients, especially patients with sexually transmitted disease. I don't trust their memories, like because they will not know. So I just assume, for me, I just assume that the infection has been there for years. And for some reason, we just discovered that we just discovered that in this premarital test, for example. And for those guys, like we usually give 3 consecutive weekly doses of 2.4 million units. As I mentioned before, a 4-fold decline in the RPR titer is needed to confirm a good response. Herpes simplex virus is a genital herpes, and syphilis are the primary causes for genital ulcers. At risk in at-risk sexually active patients in the United States. So herpes and syphilis are the most common of ulcerative STIs in the US. The diagnosis is still the nucleic acid amplification testing is more sensitive than culture. Treatment, we have 2 options, and this is like the new updates we have. We used to have episodic treatment for acyclovir till the TID, till the lesion crusts, or valcyclovir 1 gram orally BID till the lesion crust. However, we now have a suppressive therapy, and this treatment is recommended for those with recurrent herpes simplex virus infections or HIV patients, and this is like a regimen that they will stay on for the rest of their life. So acyclovir 400 to 800 milligrams orally BID, or valcyclovir 500 milligrams BID. I've never seen any patient, not even in the infectious disease clinic, where they are on suppressive therapy till now, but it is there in the literature, and it has to be mentioned. So that's it for the STI, and so the recommendation. So I would like to emphasize on the most important thing, like Mycoplasma genitalium is a big player that's coming into the picture of urethritis, and testing it, and it should be considered in testing for patient with recurrent or persistent urethritis. Treat gonorrhea with a single intramuscular ceftriaxone injection, 500 milligrams. I will not go into the details, but like there are like differentiation. If the patient is less than 136 kilograms, 500 milligrams is enough. If he's really heavy, we can increase it to 1 gram IM. Co-treatment with azithromycin or doxycycline is no longer required. So be careful when you see that, and try to look for the year of guidelines that you guys are going to follow in the exam or something like that. Screen pregnant people with syphilis in high incidence area and those who have risk factors at the time of the pregnancy diagnosis at 28 weeks gestation and at delivery. This has not been changed. Routine treat of pelvic inflammatory disease with 14 days of metronidazole, 500 milligrams twice per day, 14 days of doxycycline, 100 milligrams twice per day, or an intramuscular ceftriaxone at an increased weight-based dosing to cover gonorrhea. Now we move to the last bit of, I don't know how long we have. We have 9 minutes, so I'll just fly through it. I always like the historical background. So HIV was first documented in the United States in 1981, but who knows how long it has been there before it was documented for the first time. Screening is the paramount in identifying early infection and is now a routine component of primary care. We just do screening for HIV for many things. Someone who's applying for a job, we just do it. Someone going for the university, we just do it. Someone is getting married, we just do it. Someone is changing his job, we do it. So pregnant lady, whenever she's getting pregnant, we just do it. So we have discovered ways, like smart ways to implement the screening of HIV without giving it a much of a stigmatic picture. Primary care physicians are also often involved in monitoring patients with infections. So our job is not just to diagnose him, send him to the infectious disease. No, we should be involved in monitoring the patients. Diagnosis can occur at any stage of the human immunodeficiency virus. Appropriate management with a combination of antiretroviral often extends the patient's lives, sometimes for many years. However, will never treat them. Selection of pharmacotherapy is usually based on the genotype or phenotype resistance testing. And we will come to the importance of that and what is genotype or phenotypic resistance testing. A comprehensive laboratory evaluation, including HIV viral load and CD4 lymphocyte monitoring, is necessary to guide the decision-making for treatment, opportunistic infection, prophylaxis, and vaccination. So let's talk about the current status of HIV. Unfortunately, we don't have a clear numbers here in Qatar or the GCC. However, in the United States, they are taking HIV very seriously, and nearly 1/2 of the estimated 1.1 million people with HIV infection in the United States are not receiving antiretroviral therapy, or maybe they are receiving antiretroviral therapy, but it's not sufficient. This could be due to many reasons, like is they either don't have insurance, or maybe the insurance will not cover the full treatment for it. And those treatments are really expensive. Approximately 38% of the new transmissions are from people who are HIV ignorant, like they don't know that they have HIV and they've never been tested for some reason. And it has been a while that it hasn't ever been tested for, so they just end up transmitting infections to other people. So diagnosis, in the meantime, like testing with the 4th generation combination HIV antigen antibody immunoassay is widely available. And this is what we usually do in the meantime. And I believe in Kuwait, they are doing it the same thing. The USPSTF is recommending that type of treatment, the 4th generation combination HIV antigen antibody immunoassay, the screening for people between 15 and 65. Okay, and those who are at risk, like if you have someone who's at risk, just do it. If he's between 15 and 65, ideally, I would not say ideally, but I say most likely they are engaging in risky behavior. So that's why they are recommending for treatment, for screening. The 4th generation HIV test detects a protein or an antigen that is called P24. And the good thing about this P24, this can start to appear as early as 2 weeks of the infection. And this is what they call the rapid test for HIV. This was advertised back in 2009, I believe, like when it came in, like this was a breakthrough. This is the rapid test, and it can detect infection as early as 2 weeks. Acute symptomatic HIV is often under-recognized, because as you know, like in the acute infection, usually they will come up with non-specific symptoms. So they just come with a runny nose, fevers, sore throats, things that we can take it lightly. And fewer than 50% of people who have identifiable acute illness. The initial examination generally shows no specific HIV-related manifestation unless symptomatic acute infection or evidence of HIV is present. So we have to stay open, and we have to always include HIV for those who comes with recurrent infections, like unexplained infections. Laboratory testing should include primary care settings. It's primary care screening. So that's the first thing that we always do, screening for the infection itself. And HIV-specific baseline laboratory testing with a CD4 count. CD4 counts is very important as it can dictate what type of intervention I can do right now. Quantitative plasma HIV RNA viral load is also important as well. And HIV drug resistance assessment, which is the genotype and the phenotype that I have mentioned earlier, is very important. I'll tell you why now. So the recommended baseline and follow-up laboratory tests for HIV. So it's, as we have mentioned, CD4 is always there. HIV resistance, the genotype is always important. And this is very important as it could tell the characteristics of the virus itself, and how, and it could dictate which antiretroviral can be the most appropriate in reversing the multiplication process. HIV viral loads as well is always needed. Other tests are needed as well, such as hepatitis A, B, C, sexually transmitted infection, because, you know, like people with HIV, there is a high chance that they will end up, you know, like with other more common sexually transmitted infection. TB should be tested there, you know, like annually should be tested and screened for those patients with HIV. Okay. For the management, antiretroviral therapy should be started as soon as possible after the diagnosis to reduce the HIV-related morbidity and mortality and reduce the transmission risk. Identify and address potential barriers to treatment and adherence. You have to ask him, you know, like what could be the possible reasons. In the United States, they always mention, you know, like I cannot afford it. They just cannot afford it. But here, you know, like other things that could happen here, you know, like as a stigma, you know, like stigma is always there, you know, like I don't want anyone to see that I take antiretroviral or see me go frequently into the infectious disease clinic. Antiretroviral therapy can be initiated before the baseline drug-resistant test. Remember the genotype? I don't have to wait for the genotype, even though it can tell me which treatment is the most appropriate one. However, I can start there are like regimen for initial antiretroviral therapy that can be given as soon as possible. And then once the treatment or once the results for the genotype testing comes back, we can alter this or we can adjust the treatment approach. These are the recommended initial antiretroviral regimen. We as family physician, we don't really need to know all of it, but you know, like it's just giving you an example of what options do we have in case in the future we have it. However, one of our main roles, you know, like is the opportunistic infection and monitor for opportunistic infections. Okay, so there are like landmarks in the CD4 count. So we have the 500 less than 500 CD4 counts. So at this point, we should consider always keep in mind, you know, like TB as a cause for opportunistic infection. Less than 200, we have to think about pneumocystic jirovecii pneumonia. Less than 100 toxoplasmosis is always there, and we should start treatment for it. Less than 50 MAC or Mycobacterium avium complex. We should consider it all the time and start prophylaxis for them. This is, you know, like the organism. So for the TB, as we have mentioned, that screening should be done annually. And if the screening test is positive, the first step is to rule out any active disease. If there is no active disease, start prophylaxis isoniazid for 9 months. For
interruption.
Sorry, yes.
But the time finished, Doctor.
I have 2 minutes, 2 minutes and I'll finish.
Okay.
For less than 200, you know, like trimethoprim sulfamethoxazole is the prophylaxis that should be started without even waiting for a test. For less than 100 toxoplasmosis, trimethoprim sulfamethoxazole should be started as well. Vaccination, at vaccination, you know, we have to consider always, you know, like hepatitis A, hepatitis B, herpes zoster, HPV, influenza, which is inactive only, so we cannot give live attenuated, meningococcal, pneumococcal, and tetanus. If the CD count is less than 200, just avoid, you know, like live attenuated vaccines. This is the last slide, I believe, you know, like all people between 15 to 65 should be screened for HIV at least once. All people who are pregnant should be screened for HIV. Combination of antiretroviral therapy should be initiated as soon as possible. Combination of antiretroviral with durable viral load, with a durable viral load suspension is recommended for patients with HIV to reduce the risk of sexually transmitted infection for seronegative partners. So it has a role, you know, like in preventing transmission as well. If the CD count is less than 200, consider trimethoprim treatment or prophylaxis for pneumocystitis. If it is less than 100, toxoplasmosis always there, and you have to start the treatment prophylaxis for it. Most vaccination can be administered according to the adult vaccination schedule. Live vaccine should be avoided for people with the CD4 counts less than 200. That's it. Thank you very much. And I leave the floor for you guys, like for any questions. And yeah, these are my references.
Thank you دكتور خالد for the informative and interesting lecture الصراحة يعطيك ألف عافية.
الله يعافيك.
بس دكتور بنفس الوقت عندنا many questions صراحة. في one questions in case if I have a high suspicion of Clostridium difficile,
Yes.
based on the history, should I start the patients in oral vancomycin after they provide the stool sample before the result is obtained?
Well, like this is another updates, it's there. I remember in our time, vancomycin was the first option. Now it's not the first option anymore, by the way. Like it steps back to the second step or the second preferred treatment. However, like as I mentioned, like C. difficile, if you have a patient who has been taking an antibiotic for the last 3 days, we started him on antibiotic, any antibiotic for the last 3 days, or he has been in a hospitalized in the last 12 weeks, say like 3 months, he has been hospitalized in the last 3 months, just do the test and start the treatment. Okay, so can you see? So we are reducing the threshold for C. difficile right now, like even if there is a hint, just do it. Okay.
But there is another question. When would you refer a child with scarlet fever to secondary care?
Well, the thing is, scarlet fever, like if we start him on an antibiotic as soon as possible, usually, let me tell you about the situation here. Usually in Qatar, if I send a child with a scarlet fever to secondary care, I will have the biggest datex in my in my life, like as an inappropriate referral, because scarlet fever is a disease with a very good prognosis. If I start him on a treatment, I don't have to send him. However, let's say for other things, like sometimes the scarlet fever or the patient with scarlet fever, they will not come to us in any way, like if they have complications such as febrile seizure, and this is possible that they might have this febrile seizure, they may not come to us. But honestly, for me, I've never seen any guidelines where I have to refer a patient to the secondary care for scarlet fever, and I have never seen it, honestly.
Thank you, Doctor. What is the duration between treatment and repeat testing for syphilis to look for treatment completion?
Okay. For syphilis, let me tell you based on my exam, because I was doing the premarital test. So usually I used to give them 3 weeks an injection. So I used to give them the 3 weeks injection. And then after that, I wait for about, if I'm not mistaken, 3 to 6 months, like this is the period to see a good response. It's like always 3 months. I ask them to come 3 months, but usually we tell them come in 6 months, because this is the period where their certificate will end. Okay, but it usually takes time. It takes time, like I will not say, maybe it's I can't really remember it, but usually I used to tell my patients like 3 to 6 months.
Good, Doctor. Good, Doctor. There is one question asking about the sugar. If the sugar increase the diarrhea, and what about the rice water?
The rice water.
Yeah.
Yeah, usually when it
And
comes
the sugar. Sorry.
sugar, do you mean like patient with diabetes? Should I give him the
No,
sugar?
no, sugar. If the increase the diarrhea or يعني advices, if you want to advise the patients.
Okay, yeah. Like for advising diarrhea, like because my biggest concerns here is the dehydration, right? And when it comes to the dehydration, I have to replace them with the electrolyte. So if you think about it, like the tablespoon of sugar, like mostly the most recommendation is like only 2 tablespoons of sugar. So those 2 tablespoons of sugar, like they accounts for, I think, 50 milligrams of glucose. So the risk for diabetic patient is not there. So that's a concern as well. However, I know that some people might say that sugar can increase diarrhea. Is this the question, that sugar can increase diarrhea itself?
يعني when we
But
advise the patients, you have to stop the sugar. Anything
yeah.
with sugar, you have to
Y-
stop it.
Yeah, I know, but the thing is, like still sugar, we still need it, like because to replace the electrolytes, like and two tablespoons of sugar has been added in most of the recipes in according to the American Academy of Family Physician recently in 2022. The last update was in 2022, and they have added sugar. I remember it was only salt, but right now they have added sugar like in all of them. And that's why they have mentioned Gatorade, which was like very weird, like why would you add sports drink, like as a replacement therapy?
Good, Doctor. Doctor, there is another question. What is the confirmatory test for HIV? CD4 or viral load?
It's none of them. CD4 and viral load is for the profile, is for the prognosis of the disease. Like remember for the HIV, we do have the P24, which can tell us, like with a very high sensitivity and specificity, the patient is having HIV or not. The confirmatory testing is PCR. Okay, so we do the PCR for it. However, the viral load and the CD4, we use them for other purposes. We use them to tell if the patient has reached the point of AIDS or not, because AIDS is not HIV. AIDS is a very late stage of HIV. So if the CD4 points, if the CD4 score has dropped below certain points and the viral load is really high above a certain point, that's when a patient is having a probability of contracting opportunistic infection. And this is the only reason we do them frequently, because if you notice, we do CD4 and viral load frequently. Why would I do a confirmation test frequently every year or every 6 months, right?
Yeah. Okay, Doctor, there is consent needed for suspected cases of HIV. And if yes, it is verbal or written consent.
Depending on the policies. In Qatar, we don't give a consent. You want to apply for a job, the job asks you mandatory, like to go and do the test. You go in for getting married, like it's by law, you have to do the screening for HIV. In Qatar, I've never seen any, I've never offered any consent to do the testing, because usually they come ask for it, doctor.
Oh, good, Doctor. Doctor, there is another question. What is the easiest way to differentiate between the measles and rubella, given the overlap of the symptoms?
Well, rubella, like measles, as I have mentioned, like measles, always remember the 3 C's: coryza, conjunctivitis, cough, along with a very, very sick patient. If you see one measles patient, like you will never miss him again. Very sick patient. Those mucosal, because, like as I have mentioned, like measles start with the mucosal membrane. So once you have, and these 3 characteristics, these are the mucosal membranes, like that can only be specific to measles. So this is, this can be the very distinguishing sign between measles and rubella. Rubella can come in the same way, but rubella usually they will be less severe. They will not be as fatigued as measles. And the last thing is the rash, the nature of the rash and the distribution of the rash. For the measles, like starts in the face, neck, and then spreads elsewhere. For the rubella, it's usually they will have a large lymph nodes and the rash is like not as generalized as measles.
Good, Doctor.
And they will not have conjunctivitis, coryza, and cough as well. Not necessarily.
اوكي دكتور. ثانك يو سو ماتش دكتور خالد، ونتمنى نشوفك بالكويت عن قريب. يعطيك الف الف عافيه
ان
دكتور.
شاء الله، الله يعطيك العافيه. والكويت بالعكس بلدنا وشرف لنا والله نكون معكم.
الله يرحم والديك دكتور.
الله يجزاك خير، مع السلامه.
العافية.